the prevalence of trauma,
Mm-hmm.
where all of this wisdom is really coming forth really rapidly. For so long, we really didn't have a full understanding of these things. We thought that this all just like lived as intellectual stories. And if we talked about them enough, then we would someday feel better. But now we're starting to know better. I think that it's reasonable to expect that our practices and our structures and systems can start to create space to support us in this way.
Hey, what's up, everybody? Welcome back to Nursing Uncharted, the podcast that dives into all the different ways that we can use this license and uncovering uncharted conversations in the process. We are in the middle of a two-part series today talking about end-of-life care, what that looks like in the hospital, and how we can help facilitate those transitions for our patients with grace and respect and dignity. If you haven't listened to part one of our episode, you should go back and listen to that one first. This is a continuation of our conversation from part one. And we talked about some really, heavy, wonderful stuff that I would love for you to hear. If you work in the hospital, in the ICU, or, even on the floors, we can get so caught up in policy or stuck in our mindset of healing that we lose sight on how to properly care for these dying patients. And it ends up being an emotional and mental toll on us as caregivers. And it's a big driving factor of burnout in the hospital. So I'm sitting down with Melanie Sheckels, also known as the Threshold Doula. She's a death, grief, and trauma educator and guide who has helped hundreds of humans move from fear of death into pleasure, possibility, and peace. Through her practice as a death doula, she guides dying people, families, and caregivers through thresholds of profound loss and change towards stability, vitality, embodiment, and trust. She believes that death is a sacred rite of passage, not a medical event, and that even amidst great loss and difficulty, we each contain an inherent, unbreakable blueprint of health and wholeness that we may return to with deep, consistent care and connection. Melanie is also the host of the Death Jam podcast and community event. So, Melanie, welcome back to the show.
Oh, thank you, Maggie. It's so good to be back with you.
Yes, I'm really excited to continue this conversation. So I wanted to focus a lot of this part two on, tips really that we can provide nurses specifically for caring for those patients, how we can retain our emotional and mental energy, while also being able to care for others. I think that taking on end of life patients can be, it's a cognitive shift that you have to make before you enter a room and before you take those patients for the day. And I think it can be jarring for nurses because of the culture, I think that sometimes we fall short in the hospital with. So I want to kind of focus this conversation on how to care for those patients and how it can be empowering and rejuvenating as opposed to, worsening burnout.
Mm-hmm. Yes, absolutely. And so, a theme that we talked about in the last episode was the energetic weight that is upon us when we are in this role of trying to fix and control this way of being in the hospital. If we can, we should.
Yeah.
And when we're approaching end of life care with this particular way of being, the weight of that can really be unbearable. So one of the first tips that I like to offer people is that in the care of dying people, it is really powerful and important for us to learn to trust the wisdom of the person who is dying, trust the wisdom of their body.
Mm. Yeah.
And so often as nurses, we're moving from a place of, you know, and I think this can be very subconscious, but this the science knows best.
Yeah.
The data knows best. The doctor knows best. Um, I know best,
Yeah.
and so it can be very easy to for that to override
Mm-hmm.
really listening to whatever wisdom is coming from this person's dying body.
Yeah.
And so as a person starts to transition into that process, um, their needs change, their drives change,
Mm-hmm.
and to make the transition to trusting that and allowing that to happen is, I have found that to be like a huge relief of the weight that I'm carrying as a caregiver.
Mm-hmm.
And it also really helps to honor and support the person who is dying.
Yeah. Yeah, absolutely. I could see how that could be, once you relinquish that sense of, I'm responsible for this, the way that this is, I have to have the answers for
Hmm.
how to go about this process. Instead, if you can just surrender to
Hmm.
what the patient is feeling and what they need, and trust that they're giving you the feedback that they can give you, and that's all that needs to happen. You don't have to have all of the answers in that time. I'm
Hmm.
sure that weight, it lifts a lot of the weight there.
Yeah, yeah. And I think that what I've experienced working in the hospital is that we are really taught and conditioned that um, I don't know. I guess I've witnessed people, elderly people, and people that are closing on that window of entering into the dying process. I've witnessed their sense of consent and autonomy um, be taken away from them pretty quickly,
Mm-hmm.
in the sense of, oh, this person is no longer accurately able to tell me what the date and time and precedent is. So
Mm.
they're confused. So they're not able to accurately choose for themselves. But what I'm suggesting here is that even if this person doesn't know who the president is or doesn't really know what season it is, that when they tell you, I I don't want to take that medicine. I I don't want to get out of bed right now. I
Mm-hmm.
don't want to have a, a catheter inserted into my body.
Mm.
Whatever it is, that they're still in relationship with their inner knowing of their limitations, and so
Mm-hmm.
that matters and that can be trusted. Even if the person who you're caring for who is dying isn't aware of some of these aspects of their reality,
Mm-hmm.
um, this is actually a very normal part of that process.
Yeah.
You'll find that people are maybe spending more time asleep, spending more time dreaming,
Mm-hmm.
and less time engaged with reality as you and I know it.
Mm-hmm.
And so, if a dying person tells me that they don't know what time it is, um, that makes perfect sense to me. That is not of concern to me.
Mm-hmm.
And I would suggest that they're still able to accurately report their symptoms, how they're feeling, that they're
Mm-hmm.
still able to teach me to be a guide for how to care for them well.
Yeah. Yeah, I feel like people would more often retain their sense of how they're feeling in their body,
Mm-hmm.
even if they are may not be oriented to anything else. It's like something that's
Mm-hmm.
ever present in their body. It's like that seems like something that you could always trust, and it's not
Mm-hmm.
even, I think it's a good thing to, when you have a end of life patient, to just start to get into that mindset of, you don't need to be doing those assessments of
Mm-hmm.
if they are confused, or you don't need to be asking them their name or where they are. A lot of times that's not the focus anymore.
Right, right. And that can actually be um, so disruptive, and it can exacerbate
Yeah.
their stress with
Mm-hmm.
this experience. The body of a person who is dying is making these really brilliant shifts that that we really haven't studied quite as well as we
Mm-hmm.
have, like, how to prevent death or stave it off for as long as possible. But um, one example is that when a person's natural impulse to eat and drink subsides, and they, of their own volition, choose to stop eating and drinking, the body will experience these chemical shifts
Mm-hmm.
that act as natural pain relievers, that really support them in feeling more peace and more calm in this experience. So
Mm.
even in that impulse to continue to offer food and water to people beyond the point at which they no longer desire it,
Mm.
we can interrupt the body's own wisdom
Yeah.
as
So
it
just,
relates to death.
we'll be right back to our interview. Grab a cup of coffee, but don't go anywhere, because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show. We're talking about the 12 tips for regenerative end of life caring.
Mhm.
And we're talking about how the first one of your tips is trusting the person who is dying, trusting that
Mhm.
process, whether in despite, a mental state that they're in, they're still able to kind of be attuned with their own body, and just trusting that process.
Mhm. Mhm.
So
Yes.
what's your next tip for end of life caring?
The next practice that I find really supportive is to have some sort of centering practice. It may be a meditative practice. It may be something like tapping, if you're familiar with
Mm-hmm.
that.
Yeah.
It may be breath work. It might be a daily practice of yoga, or of going on a morning walk with your dog.
Mm-hmm.
Um, but having some sort of practice that you do to really ground your energy,
Mm-hmm.
it can help if it's something that you're able to tap into in the moment. So if
Yeah.
you could even take a few minutes to pop into the bathroom and just really call your energy back in.
Yeah.
So a
Yeah, I was
centering practice. Oh, sorry, go ahead.
no, I was just gonna say, in thinking of implementing it in the hospital too, like taking a couple minutes. Like when I was thinking of centering, I was thinking of just if you're feeling any certain type of way, just naming that emotion that you're feeling in order
Mm,
to just kind of get in as a way to center yourself. And so to
yes.
just be more present in the moment if you're feeling overwhelmed or maybe you feel inadequate to take care of that patient, or just kind of understanding where you're coming from, in that day, I think might be a good way to kind of reset a little bit.
Yeah, absolutely. Absolutely. I think that's super powerful. And, you know, we can name and take a moment to notice and name what it is that we're feeling. And we can just kind of take a minute to breathe and to be with it.
Mm-hmm.
Um, my personal practice would look like really just noticing that feeling, noticing what that feeling actually, how it exists in my body. So
Mm-hmm.
I'm feeling overwhelmed. I'm feeling the speed of the hospital. The way that that's showing up is like there's this maybe like tingling in my extremities. There's like a tightness in my throat. There's maybe like this speed, like I feel like my heart is moving fast. And so, like, what is one even small way that I can cooperate with these
Mm-hmm.
sensations that are in my body right now? So, even there in that moment, I might want to just like step back and forth, like noticing my feet in contact with the floor,
Mm-hmm.
feeling that energy move out through my extremities.
Mm-hmm. Mm-hmm.
And then as that wave starts to pass through me, just returning back to my breath and really just it can be helpful for me to notice some sort of resource, something in my life that helps me to feel really grounded,
Mm-hmm.
something in my life that helps me to feel that I'm a part of something bigger and stronger and wiser and more enduring than whatever these stresses are I'm dealing with in this very moment.
Mm-hmm.
And these can look so different for different people. It might be something divine, it might be something ancestral, it might be, the energy of the ocean or an old growth forest. It might be your dog.
Mm-hmm.
It might be a little one that you love that makes you want to be the best person you can be, that reminds you of like these future generations that will inherit this earth. And so when I connect myself
Mm-hmm.
to um, a field of energy that takes me outside of the scope of my one little life,
Mm-hmm.
then I feel, whew, I feel so much energetically stronger
Mm-hmm.
than when I walked into this bathroom.
Yeah.
and I have on board like this resource that's so much bigger than me.
Yeah. I feel like it takes the responsibility and the weight. It dissipates it a little bit because
Hmm.
you can be a vessel, to like
Yes.
help this transition that's so much bigger than just you, than just,
Hmm. Yeah.
Mm-hmm.
And I think that this is a really powerful practice to have on board when you're working with in the hospital and you're going from room to room. And in each room, there's such a unique and complex situation.
Mm-hmm.
Um, and going from like an intense phone call with a doctor or with a family member. And so really just take a moment to kind of clear that
Mm-hmm.
before you walk into that room with the person who's dying. And I want to name that, like, I named a specific practice that I find really powerful. And I know some folks that their meditative, their grounding practice looks so different than me. It looks like you know, I take a break and I go do a couple of flights of stairs for a
Mm-hmm.
few minutes and just like get in my body and then get
Mm-hmm.
back in the room.
Yeah.
Um, so whatever that looks like is really just perfect for you.
Mm-hmm. Yeah. I think it's really important to if you feel yourself kind of enveloped in the situation and that you
Hmm.
are in a headspace that you can't get out of, just any kind of, I used to, a lot of times when I worked in acute care, I would get like really caught up in people's situations. Something that would help me is thinking about other, things outside of work, just like immediately, like, what am I having for dinner?
Mm-hmm.
Just to kind of, just make a distinction of, this is my job, and this is something that this is a role that I'm playing, I'm being
Mm.
for somebody, but it doesn't have to envelop my whole being in this
That's
in
right.
this moment, because I think
Yes.
we do get so caught up in our days. I mean, there
Mm.
are days that I don't look at my phone. I don't, because I'm so invested in what's going on in those 12 hours, and being able to, I like the thought of, yeah, getting in your body, moving. We recently had somebody on the podcast, a clinical social worker. She, Jen Barnes. She talked about resilience in nursing and burnout, and
Mm.
one of the things that she recommended for getting kind of trauma out of your body is just moving, just like
Mm-hmm.
that extra movement, that like stale, you know, kinetic energy that like
Oh yeah.
lives inside us, that you just, especially when your defense mechanism is to kind of freeze and do nothing, like
Mm.
there's so much that gets pent up there. And just to, yeah, I love like the thought of just like taking a walk, or like going or
Mm-hmm.
doing stairs, just moving at all, that kind of
That's right.
starts to get your body out of that
Yeah.
space.
And working in the hospital, it makes so much sense that it makes so much sense that we have all of these experiences where our body would, um, where our nervous system would be signaled to mobilize a fight or flight response.
Mm-hmm.
And then it also makes so much sense that the circumstances would not actually allow for that. And those, that cortisol
Mm-hmm.
essentially just sticks in your body when we're going into that freeze response. And so having some movement and having some, just very even small doable ways of cooperating with those sensations that are left over inside our bodies,
Mm-hmm.
um, is a is a really powerful way to, um, prevent burnout and increase our capacity to be with these really big, intense situations in the hospital.
Yeah. Yeah, you bring up a great point that I've never really thought about before, which is we don't allow ourselves to naturally process these flight or fight responses. And our response to stressful, incredibly traumatic situations is met with such like a calm and like a stoicness, I think,
Hmm.
especially as an ICU nurse. And but like the body keeps score, the body
Mm,
remembers, and you have like, yeah, that cortisol buildup will catch up with you in a later
mhm.
time. You're just
That's right.
it's just, it
It might
knows
show
how
up later
to.
as autoimmune disease
Yeah.
or, if not burnout,
Mhm. Mhm.
hmm,
Absolutely.
chronic pain.
Yeah. Yeah. So, yeah, it's
Mm,
so learning how to cope with that, and understanding that is part of the job. And so that is something that, just like, chronic back pain is part of the job.
mm,
Not knowing how to process traumatic situations is can be part of the job that we have to prioritize and learn how to do.
mm, mhm.
Just like we have hover mats to, decrease the rates of micro fractures in our back.
Yeah,
Like we need interventions in place to protect our mental and emotional from
absolutely.
all of the chronic
Yeah.
things.
And we're at a time in human history where I feel like our understanding of how the nervous system works, and the prevalence of trauma,
Mhm.
where all of this wisdom is really coming forth really rapidly.
Mhm.
Um, I think that for so long, we really didn't have a full understanding of these things. We thought that this all just like lived as intellectual stories. And if we talked about them enough, then we would someday feel better. But now we're starting to know better. And
Mhm.
so I think that it's reasonable to expect that our practices and our structures and systems can start to create space to support us in this way.
Mhm. Yeah. Yeah,
It'll
absolutely. I
be
think that
interesting to
that's
see what that looks like.
yeah. I think that there are more resources. It's coming. I mean, burnout is so ever present in our profession that it's
Mm,
unavoidable at this point. And so I think a lot of institutions are naming that, and looking for ways within their culture that can help us with that. And so
mm,
it's some of the resources, it's like, okay, like I've tried to use some of the resources for burnout in some institutions, and it's very eh, like beta.
mm,
Seems like,
mhm.
but it's something that's going to evolve, I think, that, and it's something that has to be driven by us to figure out,
Yeah.
what's gonna benefit us.
Yeah. And it seems like it's become so prevalent that there's really no other option except for improvement. I think
Mm-hmm.
that a lot of these, um, a lot of these institutional approaches to a lot of these real beta approaches to dealing with burnout and PTSD, you know, they existed alongside a real sense of stigma of even just naming that you felt burnout, that
Mm-hmm.
you had experienced trauma day in and day out to the point that you were not able to function really well.
Mm-hmm.
And so even the language that we use about these things has evolved so much just in the time that you and I have been at the bedside. Like I
Mm-hmm.
remember when I started, we talked a lot about bullies and horizontal violence.
Mm-hmm.
And then the language shifted to talk about compassion fatigue. And even in
Mm-hmm.
that, there's like a little hint of empathy for the person who's actually like living in that burnt out body.
Mm-hmm.
Um, but it also was presented as this way of like, oh, you just have compassion fatigue, so you need to like go rest for a while and then come back and everything will be fine.
Yeah.
Because when you sleep, your compassion regenerates or something like that. So,
Yeah.
but one of the sort of double-edged swords of living through this pandemic seems to be this real proliferation of burnout and PTSD from bedside nursing.
Mm-hmm.
And so hopefully one of the positive things that will come from this experience is more awareness and more compassion for nurses and caregivers who have endured trauma.
Yeah. Yeah, I think that it's interesting to, you know, kind of put a timestamp on the different ways that we are like moving towards self care,
Mm-hmm.
because that's so right. And I think that we have kind of a riff right now where people are starting to, um, put themselves first before their jobs. And, that might look like call outs, on the unit. That might look like,
Mm-hmm.
just prioritizing themselves. And so while we figure out how to accommodate those things, there's a riff there, but I think it'll be interesting to, we're just, this is part of the process towards, prioritizing us.
That's right. That's
Mm-hmm.
right. It is it really is helpful to think of like the long timeline, the long trajectory of these changes rather than just like, oh, we've identified the problem and now like we're going to react to the problem.
Mm-hmm. Yeah.
It's an evolution to really understand the problem
Yeah.
and all the ways that the problem is not just a personal one, but it's a problem that is embedded in the culture, is embedded
Mm-hmm.
in the systems, and not just the healthcare systems. But again, I don't think these these things can be taken out of context of the societal culture that
Mm-hmm.
we're in,
Mm-hmm.
including to the um, the way that our society relates to death and dying.
Mm-hmm. Yeah.
So, because we live in a society that really puts a premium on endless growth and expansion, and that is inherently out of accord with the way that the life cycle works, which is, emergence, growth, stabilization, decay, and the cycle continues, you know. But because we're really like that decay, even that stabilization and integration is just like, oh no, we're supposed to be like constantly productive. We're
Yeah.
supposed to be, if the GDP isn't always up, 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 then we're doing something wrong. But the earth is literally telling us that that's not how the nature of life works.
Yeah. Yeah. Absolutely. Well, we're doing our 12 tips. I love all the tangents we go on because they're so
I know.
necessary. So we talked about
I was
trust
trying to
the
bring it back.
I know, yes. We were on the right path. We're
Yes.
always on the right path. So we talked about trusting the person who's dying. We talked about centering yourself. So the next one is attuning yourself.
Attunement. And, once we've really centered ourselves and grounded our energy, Then we're able to give care from a place of deep attunement. Then we're able to move at their speed
Mm-hmm.
rather than the speed of the hospital.
Mm-hmm.
We're able to slow down, bring our full presence, and really notice what's true for this person. And this can be so powerful, particularly when a person's transitioned far enough that they're no longer able to speak to us.
Mm-hmm.
So this can help us really titrate our interventions and really slow down before we do anything and just say, this person, I trust that their body knows how to die.
Yeah.
I trust that their body will do just fine at this without me helping. So,
Yeah.
what is actually going to add to this person's experience?
Mm-hmm.
And maybe what's going to add to their experience is simply your trusting, attuned, grounded presence.
Yeah. Yeah. I think just allowing yourself to slow down to that pace is it's so important. And it's not just slowing your body down, it's slowing, you know, your just your headspace, your mindset of what you're doing when you're in the room,
Mm-hmm.
you know, and changing, yeah, you're right, changing some of those interventions. I think about, comfort care measures on patients in the ICU, and something that we don't do, that we're not comfortable doing, is turning the monitor off. Like, you
Mm-hmm.
just, you don't need to watch. You
You
don't need
don't.
to watch the oxygen
Mm-mm.
go down. The families don't need to watch the oxygen
Mm-mm.
go down.
No.
You don't need to know exactly the last heartbeat. Like, this
Mm-hmm.
is, that's not, I think the shift that we make, the point that you make in the very beginning, is that, trying to shift the focus away from death being a medical event. That's, I think it's a big distinction that we are uncomfortable making in
Mm-hmm.
such a intervention heavy environment. you know um,
Mm-hmm.
Shifting that focus to the patient, attuning to what they need, and slowing down your entire environment. It's difficult, it's uncomfortable, but it's not about us in that time. It's
That's
about
right.
them. It's about
Mm-hmm.
their family's experiences.
Mm-hmm. That's right.
I mean, I know, like, in acute care, I feel like we do a pretty, the monitors just aren't there the way that they are in the ICU, and so I think in that respect, I think acute care does it a little bit better, in that we're really, if you want to measure somebody's oxygen, you have to, like, bring like, wheel the Dynamap in there and check it. It's not something that just sits on their finger and is watching. But it can cause so much undue, unnecessary,
Mm-hmm.
anxiety for caregivers and even us too. It would help so much. And I don't know if that's maybe a cultural thing from in my experience, or if other places do it differently, but I think I would bet that a lot of ICUs have trouble turning the monitor off
Mm-hmm.
in order to slow down.
Yeah, my experience is that in all levels of care within, the medical system, we really struggle to turn off the monitors, so to speak, whether it's the literal monitors or just to discontinue interventions.
Mm-hmm.
Um, and it's so funny to me that I remember, this early lesson in nursing school of, our ethos as a nurse is to first do no harm.
Mm-hmm.
And yet, from where I stand now, if I were to guess what our ethos is, I would guess it's if we can, we should. We should do, do, do.
Yeah.
And so, what I've experienced in, being a death doula for folks who are in ICUs, in med surge units, in long term care, or even people who are dying at home with home health caregivers,
Mm-hmm.
is that, healthcare workers are very conditioned to err on the side of continuing protocol,
Yeah. Yeah.
whatever that looks like. Doing routine vital signs. Um, and this is tricky because, like for hospice care, we are required to document a person's decline.
Mm.
And for holistic end of life care, I am certainly not documenting a person's decline. I'm simply like bearing witness to, you know, um, to what they tell me and to what I observe, and orienting myself to relate to their experience in a way that they have told me is meaningful to them,
Mm-hmm.
rather than in the way that is meaningful to Medicare.
Yeah. Yeah. It's so unfortunate that so much of our interventions are driven by insurance and Medicare and all of that. It's ever present in the hospital.
Yeah. Yeah. And it's a system that is, for better or worse, it's the system that we have. And I find it particularly challenging to reconcile, um, to reconcile their needs with the needs of a dying person,
Yeah.
which I have a very strong view that it is not a medical event. But, you know, where we're at in our culture is that when we enter the end of our lives, that's a time period when, um, statistically speaking, people are utilizing the healthcare system the most.
Mm-hmm.
And so, you know, not necessarily to throw the baby out with the bathwater. This is just where we are. And like, how can we orient towards where we are in a way that supports the people who are living and dying inside the system with the most sense of compassion and reverence for their lives?
Mm-hmm. Yeah. I think that kind of segues or ropes into another um one of your points is discernment regarding interventions and just being intentional, about the things that you're doing,
Mm-hmm.
and being okay with saying I'm or taking off your hat of this is the policy of my hospital. This is, and kind of figuring out how can I be an advocate for this person, and what does that look like within the confines of the hospital, you know.
Mm-hmm. Yeah. And this is very interesting and tricky, and without it's I'm like, huh. I don't want to maybe say everything that I'm thinking here, but I guess what I do want to say here is that it can be really helpful to get really clear on the rationale for different interventions
Mm-hmm.
when we're caring for someone who's dying. And again, to reflect back to that creative first, do no harm. So, um, which means before I do something that may have a negative impact
Mm-hmm.
on this person, and this person has, these these goals for their care, which is they want to have the most peaceful and dignified and consensual experience with death possible. Okay, so I'm coming in this room to because I'm supposed to check their vital signs and I'm supposed to reposition them.
Mm-hmm.
So really doing that work of trusting, centering, and attuning allows me to think critically from that grounded place of, okay, so repositioning them every 2 hours is meant to promote skin integrity, to
Mm-hmm.
make sure that their skin stays intact. Now, is intact skin integrity really an appropriate goal for someone who is actively dying?
Right. No.
No, no, it's not. But what is an appropriate goal for someone who's actively dying is sleep,
Mm-hmm.
um, being
Yeah.
comfortable. And so perhaps rather than repositioning them every 2 hours, I can walk in and attune to them and even observe, do they look uncomfortable
Mm-hmm.
or do they look calm?
Yeah.
Is their brow furrowed? Are they sweating? And then maybe
Yeah.
I do want to go ahead and do some gentle repositioning. And it doesn't have to be a full, like, we're getting in there and we're like,
Yeah.
you know,
Right.
heaving them up in bed as high as
Yeah.
we possibly can.
Mm-hmm.
But maybe then we're just like gently sliding pillows.
Mm-hmm.
Maybe we're getting an extra set of hands, someone who can really like, hold that person
Mm-hmm.
in a very gentle and loving way while we, scoot a fresh bed sheet underneath of them or something along these lines.
Mm-hmm.
But yeah, just really like fine tuning those interventions.
Yeah. And having just the focus always go back to what the patient needs as
Hmm.
opposed to what you are used to doing because, you know, certain interventions that are geared towards healing, it's like
Hmm.
that's not a goal anymore.
Yeah.
Like the goal is to, keep them comfortable. And
Hmm.
so, if
Yeah.
that's, turning every 2 hours and yeah, it's yeah, I really that's one of these points that I think hits home the the most in the sense that, ways that we need to rethink the way that we do things in the hospital is just making sure that you're aware of the interventions that you're doing and why you're doing them and
Hmm.
just attuning all of those interventions specifically to what the patient needs rather than what you
Hmm.
are doing for your other patients.
Yes.
So let's move on to the next one. So validating their grief is your next point here.
Yeah, I think that this is so powerful. I know that I've both experienced this as a nurse and witnessed it when I was working in the hospital. Is that when we're used to doing curative care, um, we can be very uncomfortable with the feelings that people have about loss, the feelings that
Mm-hmm.
people have um, about death and about all of the changes that they're experiencing as they move through the end of their life, all of the
Mm-hmm.
little losses that happen along the way. And because we're approaching our work from this place of, problem solving, it
Mm-hmm.
can be really easy to want to fix their feelings for them.
Yeah.
And so just having some practice um, of noticing their feelings, of being beside them as they're having feelings and reflecting back to them. Oh, I hear this. I hear that this is painful for you. I hear that this is griefful. I hear that this is really big. I see that.
Mm-hmm.
That's real.
Yeah.
And
Yeah.
I don't know what this feels like. And there's nothing that I can do to take this away for you. But I just want you to know that I'm here with you in this.
Mm-hmm.
And I know that this really matters. And I know that I will be in your shoes someday. But today, I'm not there. I'm just here beside you. And so, whatever you're feeling is perfectly valid. And just let me know how I can best support you in this moment, what support looks like for you.
Yeah. I really appreciate those, almost like those prompts, because I think it is so easy for us to, we just don't know what those conversations look like a lot of times when we're uncomfortable with having those conversations. It's so much easier to say, it's okay. Or, and just that, because we're uncomfortable, the reality is what they're feeling isn't going to change. And that's more, about us trying to make them feel better. And I
Mm-hmm.
think a lot of people just don't know how to navigate those conversations. So just
Yeah.
like having a little bit of just, what providing examples of what you can say in those moments, I think is really,
Mm-hmm.
really helpful. Just being like, I don't know what you're going through. I will be in your shoes someday, but today I'm here with you, next to you, going, helping you through this, or
Yeah.
helping,
Yeah. And I think that it can be really common to walk into a patient's room and maybe to find them upset or crying and to sort of freeze in that moment
yeah,
you know um and then from that place of freeze, just sort of like reacting. And in our reaction, we're essentially reacting to our discomfort with the sensations in our body.
mm-hmm,
And so, um, if it feels doable to even just listen and not say anything,
mm-hmm,
that would be totally, totally wonderful and validating. And if it doesn't feel doable, I would suggest moving back to that centering piece of just saying, like, I'm going to be right back with you. And I need to go take a moment and just tend to your own
yeah,
sensations. Go back to that centering piece. Be with that for just a
mm-hmm,
moment. You don't have to move from that
mm-hmm,
in terms of you don't have to act from that place of freeze and overwhelm and discomfort.
yeah. I think about, I think sometimes we tend to not engage because of I mean, we see so much pain and suffering in the hospital that I think we become desensitized to it. And I think being, I almost, I think that sometimes we feel like if we let ourselves be there in that moment for every patient that is suffering, we give so much of ourselves, or like there's a fear of giving too much of ourselves, I think.
Mm-hmm.
Um, and that, at least I felt that way before. Like, but I think I was in a really, I was definitely burned out when I felt like I was being so compassionate and thinking of, you know, being so empathetic was taking a lot of emotional and
Mm-hmm.
mental energy for me that I wasn't replenishing. And so
Yeah.
then I think that led to being desensitized to, or walling myself off. I think not being able to be there for my patients in those ways.
Yeah. Yeah. And I think that you bring up such an important point. And um, we talked about some of these practices that help to build our capacity to
Mm-hmm.
be with people in these really intense experiences. And so I think if I were to add another tip right now, like be gentle on yourself and
Yeah.
don't hold yourself to a standard of perfection,
Mm-hmm.
and having access to a capacity that you have not grown yet.
Mm-hmm.
You probably wouldn't go out tomorrow and decide to run a marathon and then get mad at yourself because you weren't amazing at it without doing any training.
Yeah.
And so this is much the same. These are muscles that we get to grow. And, you know, if you are that nurse, if you're in the situation, just maybe see these moments as an opportunity for you to tend to your own sensations, your own grief, your own emotions, to grow your own capacity and tap out and call in a resource. Call in a social worker or a chaplain or someone who would be a meaningful support person for that person to talk to.
Mm-hmm.
I think that as nurses, you know, nurses really are the lifeblood of the hospital in so many ways.
Mm-hmm.
And you don't have to be everything for everyone all the time.
Yeah.
Let someone else step up for a minute.
Yeah. Yeah. I mean, there are a lot of resources for you know, in the hospital.
Hmm.
And figuring out what those resources are and making yourself comfortable with them, using the chaplains aren't you can talk to the chaplains too. Like they're not
Hmm.
just for the patients, they're a lot of times
Absolutely.
they're for staff too.
Hmm.
They're just a therapeutic ear. They're people that are
Hmm.
trained in therapeutic conversation.
Yeah.
And all they're so compassionate. It really, and they're so well trained in being there for others.
Hmm.
And we forget that resource is there for us too.
Yeah. Yeah. And frequently, an end of life or death doula might be a part of a care team that can also function in that way of being a person that helps to amplify that resource, that helps to create more space for the caregivers as well to receive
Mm-hmm.
care, to have someone to talk to, someone to remind them that it's okay, if whatever whatever qualities you are bringing forth to this moment are just enough, and it's okay if additional resources are needed. Your service is still absolutely perfect and needed in
Mm-hmm.
this moment.
Mm-hmm. Yeah. All right. Let's see. We've done we've jumped around in and your 12 points here. Let's see. So another one that we haven't really talked about, speaking plainly and directly to
Mm-hmm.
your patients. Talk a little bit about that one.
Yeah. So when we're talking to someone who is dying, or even someone who is maybe not actively dying, but has a life limiting disease, um, I think that it can be common for us to talk around the dying process, to avoid talking directly about these things,
Mm-hmm.
or to kind of get really in our heads and in our jargon about what's happening. Like, oh, your lab values are this, or oh, your blood sugars are this. And so, an example of this might be just like saying to someone, maybe even a family member, who's like concerned about, why we're turning these monitors off,
Mm-hmm.
and just saying, well, your mother, your father, your husband, whoever this person is, they're in the actively dying process now. And so our goal is not to, record and track this data. We record and track that data as a tool to help to control these processes,
Mm-hmm.
and to so that we can make interventions that try and keep them alive or bring them back to life. But now we're entering an active death process.
Mm-hmm.
And so we're no longer using that information to do these things. So now we're going to just try and make this space as peaceful and calm, and loving as possible.
Mm-hmm.
So, really, just naming directly what is happening and what we're doing in very plain language.
Yeah. I think that could help family anxiety so much. I think just that direct communication of,
Hmm.
bringing people back to what the situation that we're currently in, you
Yeah,
know, especially in such an intervention heavy environment. It's so easy for them to get caught up in it too, and
that's
they
right.
don't know what to expect. So they're, you know, just looking to the nurses and the staff for
Hmm.
guidance on how to go about these
Yeah.
things.
And it can really foster this, it can it can really empower our patients and our families when we talk about things in direct and plain language.
Yeah.
Whereas when we're kind of skirting around the issue, or we're so focused on our jargon,
Mm-hmm.
they can start to develop this sense of dependence and powerlessness, and this almost magical faith in our ability to
Mm-hmm.
prevent death. And then for other patients and families, they'll hear us speak in that way, and they will notice that we're skirting around. They'll notice what we're not saying,
Mm-hmm.
and it will diminish their sense of trust.
Yeah. Right. Yeah. Absolutely. What about contemplating our relationships with time?
Mm.
How does that help in the dying process?
Oh, this is really powerful. And I I think about time as it relates to death in a number of different ways, particularly in the hospital. And we've talked about the speed of the hospital a lot. Everything feels very urgent.
Mm-hmm.
Everything that needs to happen needed to happen 5 minutes ago. It's already late.
Mm-hmm. Yeah.
There's this real sense of immediacy.
Mm-hmm.
And and what I really want to say to you about time is that the people that I've worked with that are dying with a real sense of peace and ease are people who relate themselves as part of something that spirals back through history, through ancestry, and
Yeah.
forward into the future, whether it's through their own children or through the communities that they're invested in.
Mm-hmm.
And so when we relate to ourselves as like the sun in the solar system, we're at the center.
Mm-hmm.
Um, Death can feel so terrifying, like such a big deal. And I'm
Mm-hmm.
not saying it's not a big deal, but I am trying to put it into context of the thousands of people who survived, who were born into this earth and survived it and found each other and had babies. And those babies were born into this earth and survived and found each other and had more babies. And then eventually you were born
Mm-hmm.
against all odds. You know, think about all the
Mm-hmm.
different eggs that could have been fertilized. You
Mm-hmm.
would not be who you are today. But against all odds, you are right here for a fleeting moment, you know, in relative time.
Yeah.
And because you're here, you have touched so many lives in your own special and unique way. And now you're giving birth to a life.
Mm-hmm.
And that human is going to go on to touch so many other lives and possibly have humans of its own.
Yeah.
And so when your life comes to an end, I think that it can be helpful to remember that you are a part of something that spans back into time and forward into the future,
Yeah.
and that you are so much more than just you.
I think I think that's one of the reasons why people that follow a certain faith have a lot more of a um, peace. I think make more peace with their mortality is
Mm,
because they do recognize kind of this larger, you know, system that's so much larger than themselves.
mm,
And, you know, when somebody doesn't have that, it creates a lot of despair. You know, did I fulfill everything that I needed, that I wanted to fulfill in life? And,
mm.
um, you
Did I
know,
matter?
yeah, yeah. I think, yeah, kind of shifting or offering that existential perspective of, you know, that this is a part of the process. Yeah, I'm sure
Yeah.
that could be really
Yeah. And I
helpful.
see this as a way of offering a window into a perspective that, you know, transcends. Like, you don't need to have a religious faith
Yeah,
or even, you know, a defined spiritual practice to relate to yourself as something that's, as someone who's a part of something much bigger.
yeah,
And that knowing of yourself as a part of something bigger than you is a really powerful, stabilizing force when confronting our mortality.
yeah. Oh, I know I'm going to use that someday. You know, in trying to give somebody peace. You know, that doesn't. It seems like we really, in the hospital, we feel like a chaplain, it has to, like, we have to call the chaplain, and that's not always going to be therapeutic for
Mm,
people, you know, that don't practice faith. And I mean, I'm sure I know chaplains probably are also well versed in, you know, providing care
mm,
and support for people that aren't, you know, that don't follow a certain faith either. But just being able to kind of, you know, have that in my pocket of being able to, like, maybe offer that perspective, I could be
yeah.
really helpful.
Oh, wonderful. I'm so glad.
So those are a lot of the tips for regenerative end of life caring. We've gone over most of them, I would say. Um, all of them so integral for creating a meaningful, purposeful death, you know, in and out of the hospital. So I'm so grateful that you've shared those with me. I want to end this episode just talking again about your events and your podcast, Death Jams, and just how people can find you.
Yeah. Um, so I host a monthly event called Death Jam. It's essentially like a virtual community conversation around death and dying. And I begin it with a little bit of a grounding practice, a little meditative practice that helps us to um, be with the sensations that come up in our body when these momentums of fear and anxiety and sorrow come through for us. So basically, I love this conversation so much. During the pandemic, it became kind of accidentally became a place where a lot of healthcare workers gathered to
Yeah.
debrief from experiencing their own death anxiety,
Mm-hmm.
experiencing death at even a faster pace than they had before. And so I decided to shift Death Jam um, to offer it more specifically to healthcare workers and caregivers. And it's just been a really beautiful way to gather community and to bring together and weave together the wisdom and wounds that we all carry around death and grief.
Mm-hmm.
Um, there's there's this sense in the community of Death Jam that we all bring forward essential wisdom about death and dying, and that
Mm-hmm.
we all get to learn from each other and co-create this experience. So I really welcome anybody listening to this podcast to come and join the conversation. It's usually not a huge group of people. It's a fairly intimate experience, and
Mm-hmm.
everyone who comes seems to get so much out of it. Often people come and report feeling fear and anxiety when they come into the space, and when they leave, they're feeling a greater sense of ease, of purpose, of pleasure, and possibility. And so it can bring about some pretty big shifts for people. And so that
Yeah.
experience inspired me to start the Death Jam podcast, which is really an exploration of death and grief and trauma as we're experiencing it inside the medical system. But there's also a lot of bringing in the blueprint around death,
Mm-hmm.
um, around death as a sacred rite of passage, and how our our fear and emotions and sensations that we experience as we relate to death and grief can help tune us into what we need from life, can help tune us into that
Mm-hmm.
greater sense of purpose and pleasure and possibility. So you can
Yeah.
find me at thresholddoula.com, or at Instagram, threshold.doula. I'm also on Facebook, but rarely. So I would love to hear what you think. Oh, and if you go to my website, you can sign up for my newsletter and receive the 12 tips for regenerative caregiving end of life care practice.
Awesome. Well, this has been I'm so happy that we were able to sit down and give this topic the time that it deserves. And there's so many pearls of wisdom in here, and I can't wait to share it with everybody. So thank you so much for talking with me today.
Thank you so much, Maggie. This has just been such a joy to sit down with you. I really appreciate you reaching out for this.
Yeah, absolutely. All right. Well, I will talk to you soon.
All right. Bye-bye.
Bye. That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aidan Dykes for the music and editing. Until next time, take care of yourself.